Hey all, this is a chest x-ray courtesy of Dr. Andrew Taylor with Radiopedia, and it's a 60-year-old male that came in after a motorbike accident. This is a chest x-ray that you get, and obviously things jump out at you right away, but we're going to go through our standard system, which is A, B, C, D, E. A starting with airways, and drawing this airway. This is the trachea, and bring it down. Looks like here's the carina right there. So it looks like it's right off the bat it's shifted over quite a bit, because here's your midline, and that's the spine coming down. So you can see both it and the heart is shifted way over. But anyway, that's airway A. B, for bones, start off with the right clavicle here, no fractures. Left clavicle, but right here you can see this split in the clavicle right here that I'm drawing, and there's a step off right here. You can see how this bone comes here and then the step off. So this is definitely a pretty good fracture there. And we move on to ribs. This is your first rib, and it looks okay. Second rib, this is posterior to lateral to anterior. Third, fourth, and on down. I don't see any fractures there. Moving to the patient's left, first rib, second, third, and you look right here, there's a step off. See how this rib comes here, and then there's a step off and it continues here. So that's a fracture right there. You can also see it on the superior side of the rib. Let's see, I lost my count. There's 1, 2, 3. That's actually rib 4. I think we skipped rib 3. So let's do rib 3. It looks like there's a step off right here as well. So that's going to be a fracture. X-rays aren't the best for picking up rib fractures, but if you have any doubts, you can slap an ultrasound on and that'll tell you for sure. Ultrasounds are great. 5. Looks like there's a little step off here. See how this line comes, and then there's just a slight step off. So that's a fracture. 6 looks okay. 7, the interior ribs. Get the rest. The rest look okay. So that's B for bones there. The vertebrae are pretty difficult. Look at the ones you can. I don't see anything glaringly obvious. I'm not a radiologist. All right, so that's B for bones. C for cardiac silhouette. You can see that the cardiac silhouette is really shifted over. Here's the aortic arch, and the cardiac silhouette comes down here and here. So it is really shifted, you can see, because this here is the mid-spine. You can look here and see that the ribs, the spacing between the ribs are wider as well, if you compare them. So obviously there's something going on here. I'm going to erase some of this so we can see better. All right, on to D. It's not the best x-ray. Either that or it's not the best copy because we cut off the costophrenic angles, but we can see the diaphragms. Here's the right diaphragm sitting on top of the liver. Here's the left. And the right is just maybe slightly higher, which it should be, but the left is, actually the left is higher than it should be. The right should be higher, and you see they're almost equal. So that's D. Now E for everything else. If you look at the lung fields, let's start with the patient's right. We kind of know something's going on with the left already. And you can see the vascular markings going all the way out to the edge here. All the way out. And costophrenic angles, what we can see are clear. And up in the apexes, although this looks like a supine film anyway, but still. That looks all right, other than the shifting. And then we look at the patient's left, and obviously right off the bat you can see that there's no lung markings anywhere in here. And up here, there's none, no markings. And you look closer and you can see the pleurer. I'm going to trace it here, right here. Either that or here. In any case, you have a large pneumothorax, and with the shift going on, you know that it's a tension pneumothorax. You can see air over here in the tissues. This is scapula, and all right, so we know we have a tension pneumothorax. I would imagine he's, with this severe, he's showing signs of it already. I'm sure he's hypotensive and so forth, so on. So this needs to be relieved really quickly, and you can either do a needle thoracostomy, and with ATLS-10 it has changed. It used to be mid-clavicular second intercostal space, but too many providers were going too medially and hitting things they shouldn't. And as well as, especially if the patient's larger, the needles just weren't reaching, and there's only about 65% effective. So they started recommending now you go mid-axillary line, pretty much the same place where you put the chest tube, and a much higher success rate. I prefer just doing a finger thoracostomy. It takes 30 seconds to do, and it's 100% successful, and you have to put a chest tube in anyway. But still, that's your clinical judgment and your choice. Bottom line is this patient needs to have this relieved no matter which way you choose to do it. So you do a chest tube, fix him up, and I'm going to pop the next x-ray up here. All right, so this is the chest x-ray after chest tube placement. And you can see the chest tube, and it's right here. And that's in proper position. Look at the airway, and you can see that the shift is pretty much resolved. You can see the carina right here. So it's pretty much back to midline. You can see this clavicle fracture much better now. Look at this jagged bone there. So he did a job on that clavicle. And the rib fractures, let's count. Here's 1, 2, 3. So let me get that out of the way. And the clavicle is kind of overlying the third rib there, but you can still see the step-offs. And then fourth rib is, you can see that fracture, and fifth rib you can really see it. Look at that. And cardiac silhouette is shifted back over. Looks a lot better. Up there. And the diaphragm's not a whole lot of change there. You can still see that this section here isn't resolved yet. That's air, no lung markings. But up in here looks like there's pretty good lung markings out to the edge. So most of the pneumo's resolved. There's still a little bit of air in there. And then you still have quite a bit of subcutaneous air in here. And you can see a little bit starting to form here as well. But overall, it's much improved, and he's not intubated, so hopefully they fixed him up with just that. So I hope you enjoyed this podcast, and hope it helps out. Please subscribe. I would appreciate it, and you all have a great day.